So, good afternoon, everybody. On behalf of the Department of Radiation Oncology, I welcome you all to this clinical grand round. And today we are going to discuss a very important and very interesting topic. The title of our CGR today is Radiation Therapy in Benign Diseases. Most people know that radiation is meant for the treatment of cancer. Okay, so I'll begin with the introduction. Uh, I will briefly show you one of the patients was treated with us by radiation treatment, and she was having a benign disease. She's a 46-year-old female from the adjoining city, and she presented to our dermatology department in 2008 with the 10 centimeter erythematous hyperpigmented lesion on the scalp, and there was no lymph nodes in the neck. She was treated with multiple treatments, including the drugs and some interventions. But despite all these treatments, she did not benefit. And till 5 years, there were multiple regimes which were changed from one to another. And then finally, the biopsy was done, keeping in mind that the provisional diagnosis of the basal cell carcinoma. And the biopsy revealed Bowen's disease of the scalp, which is actually benign disease. Patient refused surgery because of the cosmetic reasons, and a decision was taken to treat this patient by radiation treatment. So this is the lesion. If you can appreciate, about 10 cm lesion on the forehead, which is very well visible, and therefore it is it compromises the quality of life. And sometimes these kind of lesions can be quite troublesome and as bad as the cancer or the any other malignancy on this site. So we thought it's a surface tumor, so we decided to treat this patient by surface mold brachytherapy, and this is the thermoplastic cast on which the catheter was fixed, and then a CT simulation was done. And as you can see, the activated area in the catheters, if you can see this was the area which was activated to deliver the dose to the target area, and a dose of 35 gram 10 fractions was planned, and the patient was treated on the high dose rate brachy machine. This is you can see the treatment being delivered here on the SDR machine, and this is at the end of treatment. You can see a patient has a wet desquamation, and here also you can see at the end of 2 weeks, lesion almost resolved, but patient had grade 4 reactions on the skin. And this is at the end of 4 weeks after the treatment, and this is 8 weeks after the treatment. Now you can see very clearly that the patient responded very well, and lesion disappeared completely. And in fact, hair also started coming back. If you see there was a loss of hair around the area which was treated, but now he has the hair around the area initially where there was no hair, there was alopecia. So she had a gross disappearance of the lesion along with the hair coming back in the adjoining area. So with this, we can, and this was finally published also in Journal of Contemporary Brachytherapy as well. Now we can very well say that the radiation is very effective for several benign conditions. Although radiation is known more for its anti-cancer effect, this radiation for benign condition is not a new subject or new topic. It is being done for last almost a century, but it remains underutilized in clinical practice for benign lesions for several reasons. One, the fear of radiation-induced cancer and other effects in the public domain, and even the amongst the medical fraternity, radiation is very unpopular for causing the radiation-induced cancers and other effects. Lack of awareness in the allied specialties, the patients who present to the parent departments, many times they may not know that radiation can be an effective treatment for these kind of lesions. Even in the radiation community, not many people take interest in treating the benign tumors, and they mostly take areas of interest in the oncology and the malignancies. And so therefore, this remains an underutilized weapon for the treatment of the benign disease. The last 2 to 3 decades, radiation has undergone a drastic change in the technology, and therefore the modern radiation is very safe, very accurate, very precise, and very conform. Therefore, we foresee a change in the practice, and we see that the radiation might be much more useful for the benign condition as in the past. There are textbooks available on the role of radiation in the benign disease. You can see there are 2 books available. There are others also, but I'm just showing the 2 books available. So it's not a new subject or a new topic for radiation to treat the benign tumors. Not only that, there's a German cooperative group on benign diseases that is among the radiation oncology community. If you see, this is from the Department of Radiation Oncology, and within radiation oncology community, they have a separate group called German cooperative group on benign diseases. So it's not a new group or a new technique of treatment. It's a well-established treatment for the benign treatments. This is just a glimpse of the benign diseases which we treat and which benefit from the radiation treatment. There's a long list, almost 150, more than 150 benign diseases are treated by radiation treatment. But this is just a few of them. Bounce disease, as you see in the picture, tenosynovitis, hidradenitis skin condition, then squalorrhea, aggressive fibromatosis, vertebral hemangioma, giant cell tumor, AV malformations, ophthalmology, orbit. These are actually same, macular degeneration, pterygium, keloids, gynecomastia, myositis ossificans, Peyronie's disease, and so on. There is a long list of the diseases being treated by the radiation treatment. But all these diseases can be categorized in the following headings. One, inflammatory disease like myositis, and then rheumatoid arthritis, and the osteoarthritis. These are the inflammatory conditions where radiation has been used. Degenerative conditions like macular degeneration, hyperproliferative like hypertrophic scar and keloids, functional like trigeminal neuralgia and shoulder pain or other painful conditions. Infections, we see nowadays the COVID being treated by radiation. There were a few trials, including our institute, that the COVID-19 pneumonitis was treated by radiation. So even the infections can also be treated by the radiation, and some other mixed conditions like parotid fistula and some other conditions. This is one recent new indication of the radiation treatment. It's a benign condition, although Dr. Haresh will highlight more on this in the subsequent sections. But this is one of the new emerging indication for the radiation treatment as a benign condition. And this might be a game changer because these are very common disorders which are being looked forward to be treated by the radiation treatment. To trace the history of radiation for treatment of benign disease, it goes back to 1897 when a hairy mole was treated by X-ray therapy. And in fact, the initial use of radiation was mostly for benign conditions rather than the cancers, like tinea capitis, acne vulgaris, osteoarthritis, hemangiomas, infections, and so on. There were no antibiotics in that era. So most of the unresolving infections were also treated by the radiation treatment. This is one of the first patients of benign condition treated by radiation. As you can see, the hairy mole in 1897, just 2 years after the discovery of the X-rays. And Professor Freund from Vienna, he treated this patient with the X-ray therapy. And you can see the patient being treated. And even 70 years after the treatment, you can see the deformity of the patient, because that time the radiation was quite crude. But all the patients survived for 70 years, and this is the only effect patients showed from this treatment. So although we now rarely see, in fact, I have not seen any kind of deformity with the current for the modern radiation. Then a couple of other conditions treated initially 1896 for epilation for tinea capitis, then as for hairy mole, and then the other like nevus and other conditions, acne vulgaris, they were treated the initial part of the initial era of the radiation treatment. And 1924, in fact, there was the first report about the use of radiation for the heel spur, where patients which were being treated by surgery previously, they were treated by for the first time in 1920 by the use of radiation. And in 1907, almost more than 100 years back, the X-rays were used for the pneumonia as well. It was reported in American Journal of the Medical Sciences, and even the viral pneumonias were being treated by the radiation. In this report, Ronsen therapy for the viral pneumonias in 1943. So that time there were no antibiotics available. So most of the conditions were treated by the radiation which was available during that time. How did the radiation act in these benign conditions? Because we understand the use of radiation and mechanism of action for the cancer treatment, but how does it act for the benign tumors? Exact mechanism is not well understood. Radiation has an anti-proliferative effect. It affects the growth of the cell and the division of the cell. It has the immunomodulatory effect on the cells. It has an anti-inflammatory effect in the low doses like less than 2 gray. And sometimes we exploit the side effects of radiation treatment for the benefit of the benign conditions. You can see the radiation has different effects, biological effects in different doses. Like if the dose is less than 2 gray, then mostly it is used for anti-inflammatory effect. And then 2 to 10 gray, it's used for degenerative conditions. And 10 to 40 gray, that's the range where most benign conditions are treated by this kind of dose. And rarely more than 50 gray for ablative effect, for example, in cardiac ablation and then other ablation like AV malformation, where you use a very large dose to ablate the particular tissue or a particular zone. Just one slide to show that how the radiation has been used for COVID-19 pneumonia. When the virus gain entry into the lungs, it causes the release of pro-inflammatory substances called cytokines, interferon alpha, gamma, IL, interleukin 1B, 6, 12, 18, 33, and TNF alpha and TGF beta. And that causes cytokine storm, and ultimately which causes the ARDS and the death of the patient. When we give low dose radiation to the lungs, it inhibits the pro-inflammatory cytokines like IL-1B, and it inhibits the leukocyte recruitment, and therefore it has an anti-inflammatory effect, which ultimately reverses or prevents the cytokine storm and mitigates the effect of the pneumonia. This is how it acts against the infections. And there we did a study on the use of radiation for the COVID-19 pneumonitis. We published in British Journal of Radiology last in 2021. This is one side effect of radiation treatment which we exploit for the benefit of a condition called parotid fistula. This was a patient who had undergone surgery for parotid abscess, and it was a partial parotid which was removed, and after that patient had a fistula, and that fistula used to drain into the ear, and patient used to have the continuous discharge from the ear. And this patient was finally referred to us for causing the xerostomia, which we often try to avoid in our day-to-day practice. But here we use xerostomia for the benefit of the patient. As you can see, we use the mixed photon and electron beam in our Clinac 2300 CD, and we deliver dose of about 30 gray in 15 fractions for the xerostomia. As we know, the tolerance of the prostate is about 20. Tolerance of the parotid is about 26 gray. Those we did this treatment with the dose of 30 gray in 15 fractions, and the patient was completely cured of this parotid. Different kind of effects are used and exploited for the gain in the treatment of the benign diseases. There are certain principles, do's and don'ts when we treat the benign condition by radiation treatment. Although it's a busy slide, but I will just summarize that what are the principles of the radiation when we treat benign disease. One, radiation should not be the first option for the treatment of benign disease. We must exploit the other treatments. We must exhaust the other treatments like medical treatment, drugs, medications, and in the surgical treatment. So once they fail and there is no other resort, then as a last resort, we use radiation for the treatment of benign diseases. But whenever there's an indication of the radiation treatment, one should not hesitate, because all other treatments have failed and there's no other treatment left, and therefore we should not cause unnecessary delay in the treatment of the further treatment of the patient. When we decide to treat by radiation treatment, then the technique of radiation should be very precise and very accurate, because any unwanted dose will give rise to the side effects of the radiation, because these patients are going to live for a long time, because these are benign conditions, so they will not die of these conditions. So they will live for like 30, 40, 50 years, and they have plenty of time to show the side effects of radiation treatment. So therefore, we must use the best available technique for radiation so as to give the minimal dose to the normal tissues. And whenever we treat any benign condition with radiation, we must discuss this with the patient, both pros and cons. Take the discussion further. This is the schema on the or the flow of the presentation. The details of radiation, like doses and the techniques, will be discussed by Dr. Amba Pandey. The special entity and where there is a role of radiation as an emerging option will be discussed by Dr. K. Perez, RT for cardiac disorders. Role of brachytherapy by Dr. Surinder Saini, and clinical audit by Dr. Ali. And then finally we'll conclude and summarize. So now I call Dr. Amba to further take the discussion forward.
Thank you, sir. Good afternoon, everyone. So I am going to discuss the details of radiotherapy, such as techniques, doses used in the treatment of benign diseases when they are treated with radiotherapy. So radiotherapy can be delivered with external beam radiotherapy or brachytherapy. I'll be focusing my discussion on the external beam radiotherapy. Brachytherapy will be discussed by Dr. Suninder Sani. So radiotherapy techniques. So conformity is a prime concern in radiotherapy of the benign disease because these, as sir has already said, that these patients are going to survive for longer time. So we have to avoid the undue side effect of the radiation. At the same time, we have to treat the disease. Radiation therapy can be conventional radiotherapy, which is X-ray based planning, and in the last 2 decades, we have major advances in the radiotherapy techniques which ranges from 3D conformal radiotherapy to IMRT to image guided radiotherapy and stereotactic radiosurgery. Whenever we talk about stereotactic radiosurgery, the first thing comes in our mind is gamma knife. But linear accelerator based stereotactic radiosurgery are equally effective and it has advantage over the gamma knife as this technique is frameless. Whereas in gamma knife, we need to fix the head frame, which becomes an invasive procedure. Now, so this slide depicts the current clinical indication of radiotherapy in benign diseases, and it shows that radiotherapy can be used in a very wide variety of diseases, ranging from infective condition, inflammatory condition to degenerative, hyperproliferative, functional, and focal lesion, and to almost all sites of the body from brain, heart, eye, head and neck, skin, bones, and soft tissue everywhere. The dose range which is used for the treatment of the benign diseases are mostly in the range of 2 gray as high as 90 to 100 gray. When we'll be dealing with we will see this that we use very high dose during the treatment of trigeminal neuralgia. Now I'll be dealing with the certain condition one by one. For trigeminal neuralgia, this is characterized by the recurrent brief episode of unilateral electric shock-like pain, abrupt in onset along the distribution of one or more division of the trigeminal nerve. The first line of treatment is the medical management with the carbamazepine, or sometimes the cryoablation and all are used for the management. RT is used for the refractory trigeminal neuralgia who are not a good surgical candidate. Radiotherapy technique which is utilized in the treatment of trigeminal neuralgia is stereotactic radiosurgery, as we are dealing with a target which is very close to the brainstem. So for the stereotactic radiosurgery, the MRI images with T1 weighted and T1 contrast and T2 sequences are co-registered with our planning radiotherapy CT scan and is used to visualize the nerve. The trigeminal nerve is targeted between its exit from the pons and nerve entry into the Gazarian ganglion in Meckel's cave. And the dose used for the control of trigeminal neuralgia is very, very high to the tune of 70 to 90 gray in single fraction. So these are the images of radiotherapy planning, stereotactic radiosurgery planning of a trigeminal neuralgia. In the first image, we can see the trigeminal nerve base, which is contoured between its exit from the pons and into the Meckel's cave, and it is very, very close to the brainstem, very close to the pons. This image shows the radiotherapy beams, and while planning radiotherapy, we have to be careful that these beams or these arcs should not go through the critical structures like eye or ear, something like that. We have to avoid these critical structures, otherwise they will receive very high dose of radiation. This image shows the 100% dose going to the trigeminal nerve base, as well as we try to control the dose to the brainstem with a Dmax of 16 gray. So we can see the beauty of stereotactic radiosurgery even with a linear accelerator, that dose to the brainstem can be controlled very well, and thus we can control the trigeminal neuralgia pain. These are the studies of stereotactic radiosurgery used for trigeminal neuralgia, and we can see that the symptom control is to the tune of 67 to 93% in various series, and the doses used in most of the series are in the range of 70 gray to the 90 gray in single fraction. Now, the next very important condition being AV malformation. So, when we're dealing with the AV malformation, the maximum diameter which we try to treat with stereotactic radiosurgery should be less than or equal to 3 centimeter. The compact nidus is preferred over the diffuse malformation or the dural sheath AVMs. For the radiotherapy planning, the biplanar angiography and the post-contrast MRI brain images are fused with the planning CT images for proper delineation of the AVMs. And RT doses are used in the range of 16 gray to 24 gray in single fraction, depending upon the whether the tumor is located in the eloquent area of the brain or non-eloquent area, or the target is large or small. If small tumor, we can go for higher dose. For larger tumor, we have to limit our dose to the 16 gray, as wider area of brain will be exposed to the radiation. The time to vascular occlusion is about 1 to 4 years, and the bleeding risk is reduced by 90%. This slide shows the planning of the AV malformation. This is MRI picture showing the nidus, the same nidus with the feeder vessels, and this is the DSA showing the AV malformation. And normally when we plan for AVM, when we do the contouring, we take the help of the neuroradiologist and the neurosurgeons as well, contour the exact nidus where we want to target our dose, and then we confirm the dose. Now, symptomatic amyloidosis. So here the radiotherapy induces apoptosis of the amyloidogenic plasma cells and thus arresting the amyloid production and disease progression. Diffuse amyloidosis of tracheobronchial tree. We had treated such case successfully with the radiotherapy. So amyloid deposition in the laryngeal and the tracheobronchial tree is rare, and this constitutes approximately 1% of the benign diseases of the airway. The presenting symptom can be dyspnea, hemoptysis, airway obstruction requiring tracheostomy. Our patient was a 35-year-old patient who presented with airway obstruction, hemoptysis, and dyspnea requiring tracheostomy. When we presented to us, he had a tracheostomy already. So this patient we treated with IMRT technique, and we delivered 20 gray in 10 fractions. These are the dose color wash. We can see that how beautifully the dose can be conformed to the tracheobronchial tree. And today before coming, because this patient due to COVID could not come for follow-up, so I had followed up the patient today just before coming the grand round, and we treated this patient in the beginning of 2019. Till now, the patient is symptom-free in terms of there's no episode of hemoptysis and there's no airway obstruction, though he has tracheostomy tube in situ because he could not come here and he did not get removed. He lives in Assam and he does not have medical facilities over there to do that. So the next condition being orbital pseudotumor, the inflammatory process of unknown cause, sometimes resulting in the palpable mass resembling the tumor. The indication for radiotherapy being no response on steroid, recurrence after steroid, or intolerance to steroid. The radiotherapy commonly used for this condition ranges from 20 to 30 gray at the rate of 1.8 to 2 gray per fraction per day. Now, keloid. This is one of the hyperproliferative disorder where radiotherapy is being used for decades successfully, and they have very high rate of recurrence after the surgery. The radiotherapy is delivered with superficial or orthovoltage X-ray, electrons, or brachytherapy. The role of brachytherapy in keloid will be discussed by Dr. Surinder Sani in great detail. So I am just concentrating the external beam radiotherapy. The radiotherapy dose is normally in the range of 20 to 30 gray, and most commonly dose which we are using is 20 gray in 10 fractions. It is most effective when given within 24 to 72 hours of surgery. Now this condition, heterotopic ossification, this has emerged as one important area where we are giving radiation therapy in benign conditions. With the increase in enhancement in the skill of orthopedic surgery, more and more patients of heterotrophic ossifications are being operated, and such patients are being referred to us for the radiotherapy. And here the radiotherapy is usually used within 24 to 48 hours after surgery, and radiotherapy is given 7 gray in single fraction. These are the the list of benign diseases which are treated with radiotherapy is a very, very long list. And I have just chosen some common ones which we are routinely using in the practice. I would now request my colleague, my senior Dr. Harish, for discussing radiotherapy in ventricular tachycardia.
Thanks, Dr. Ramba. And next 7 minutes, I will be confining myself to the role of radiotherapy in treating ventricular tachycardia, which is an evolving scenario. And we all know that ventricular tachycardia is the abnormal beating of the ventricles, which is more than 100 beats per minute. And most common cause being myocardial infarction, which is very common in today's scenario, and which leads to ischemic myocardium producing the signals from the myocardium, abnormal myocardium. And the important treatment options that are available as of now are anti-arrhythmic medicines like amiodarone, then the implantable cardiac defibrillators, and catheter ablation, which is RFA and cryoablations. And with advances in cardiology in today's world, these conditions have turned out to be a more of chronic disease, and more patients are surviving with these interventions. And many patients do undergo catheter ablations with RFA, and there are a lot of demerits with the catheter ablation, even though it is helping a lot of patients. It's a time-consuming procedure. You know that it takes a minimum 6 hours for the procedure, and it's got its own inherent toxicities. In high-risk patients, there can be even the periprocedural mortality of around 5%. And the other issue with needle ablations are there are some inaccessible areas like epicardial locations, and it is very difficult to reach the location for ablation. And another important thing in Indian scenario is these ablations are little costly. Radiation oncologists around the world had been using a stereotactic body radiotherapy for ablating small lesions in the locations like the lung, liver, brain, spine, prostate. And with modern advances in imaging technology, the motion management technology, and the radiation delivery machines, we are able to ablate small areas with high precision and giving minimum dose to the surrounding normal structures. Here you can see that in the first scenario, you can see a small lung tumor. We are ablated this image from our own department. We are ablated this small lung tumor by focusing high dose radiation to that area. And 2 weeks back, we treated this patient, which you can see a very small lesion just adjacent to the heart, this CA lung. And by SBRT, we have ablated this lesion successfully. And worldwide, people are gaining a lot of experience with SBRT, and people are moved to use this technology for treating benign conditions like cardiac ventricular tachycardia. And it's known as STAR, stereotactic arrhythmia radioablation. What are the potential advantages of using the radiation for this indication? It's basically a non-invasive procedure, and there's no needle that is needed, and we can do without any GA. The treatment takes only a few minutes, usually 5 to 10 minutes, not more than that. But the initial procedure planning and all those things will take some time. And radiation can reach inaccessible areas which the needle cannot reach. And when the cardiologists do the ablation, they would like to ablate the whole thickness of the myocardium, where the exit site is. So with radiation, we are able to treat the whole thickness of the abnormal area, abnormal myocardium. And it's, of course, it's cheaper, but it can vary depending on the center where you treat. If it is in a private center, it can be costly. In a government center, it's very cheap. No extra investment that you need to do. It all it didn't come in a single day. There are a lot of studies you can see which were tried on animal models, where they used different doses of radiation to ablate different areas of the heart. And finally, they had found that a dose of somewhere around 25 gray is going to ablate the target area and leading to changes in the electrical signals. And what's the mechanism of action in these cases? Initially, it was thought that it is a fibrosis due to the radiation that is causing the blockage of the electrical activity. But later on, people have negated this thought, and because fibrosis takes at least 2 weeks to settle, and even before 2 weeks, the effect starts after ablation. So the present scenario is that it's like more of an electrical substrate remodeling that works in these cases. And there is a change in the conduction proteins in the heart also that comes into the picture. So what is the workflow? There are two important methods of imaging that you need to do when we use this method for ablating the cardiac lesions. One is the anatomic scar imaging, where we use the CT scan, the late gadolinium enhanced MRI images, the SPECT CT, PET CT, for identifying the abnormal area in the heart. And other important thing is the electrophysiological anatomical mapping, where people use 12 lead ECG or 256 lead identify the abnormal exit site. By exit site, but means the initial 20-second area where the signal starts. That is the area where we need to ablate. So this helps in that procedure. And by using information from both the anatomical scar area and the ECG information, electrophysiological information, you identify the area to be ablated. And then you do a planning CT where you take 3 mm cuts of the for the patient, and then mark the area of ablation that you need, and give a margin usually for uncertainties. And in the treatment planning system, with the help of the medical physicist, we do plan the radiation for that area. And once the plan is approved, after analyzing all the indices, patient is taken on the linear accelerator, and then a cone beam CT scan is done, and patients are aligned to the right position, and delivery is done. So the first in human study for cardiac ablation was done, for ventricular tachycardia, was in 2012 by the Liu et al. From Stanford University, where they treated 71-year-old patient with VT with a dose of 33 gray. And you can see that the ventricular tachycardia episodes has declined after delivering the radiation. And the same group had done a prospective study later on, but the results are not out. Maybe in this year, or they might be publishing it. And but the path-breaking paper was this paper that appeared in NEJM in 2017, where they treated 5 patients in 2015 with ventricular tachycardia. And here you can see that these are the incidents of VTs before treatment and after treatment. There is a gross decline in the VT episodes from 6,500 episodes to less to 4 episodes after the treatment. But of course, there is a blanking period. By blanking period, what they mean is that a 6 weeks post ablation period, there will be little incidence of VT because of the inflammation that occurs post radiation. And you can see that still the incidence is only 680 episodes in that period. And they had seen that there is no reduction in the left ventricular ejection fraction after this. And there was a need for ICD stroke also decreased after the radiation. The same group, this from the Vashu, they conducted a prospective study, ENCORE VT trial. For ENCORE VT, they delivered 25 grays of radiation for 19 patients, and they had seen that there is a 94% reduction in the incidence of VT by delivering radiation. And you can see that the need for dual antiarrhythmic medicines decreased from 59% to 12% by delivering the radiation. And you can see the survival curve also. 6 months overall survival was 89%, and 12 months survival was 72%. And there was an improvement in quality of life also. And this from another group, 10 patients, there is a decrease in the incidence of VT after radiation, and the survival, long-term survival. And these are the list of active trials that are exploring this technique in this scenario from different parts of the world. And soon we are going to add to this list, and we have submitted this protocol to the ethics committee in collaboration with our Department of Cardiology and Department of Nuclear Medicine. And we are awaiting the results of the decision of the ethics committee to start the project. And this is the patient selection criteria that we have enlisted for this project. And you can see that we are planning to take 20 patients of refractory VT due to post-MI infarcts. And when we were putting up this proposal, there was one patient of post-COVID myocarditis, which had an intractable VT, which was referred by Dr. Nayak. And then we were evaluating the patient for whether RT can be delivered in this patient or not. And in fact, this helped us in doing a dry run and streamlining many of the procedures. We initially made a immobilization device for the patient and with abdominal compression, and then we did a planning CT for the patient. We used MRI and SPECT information for delineating the area with the help of Dr. Nayak. And then we made a plan to deliver radiation to this area. You can see that this area we were able to deliver. We were able to delineate 25 gray to this area, giving minimal dose to surrounding areas. All the parameters that we need to achieve were possible with this plan. But we didn't deliver the treatment for this patient because patient underwent needle ablation and patient was stabilized. So we didn't go ahead with the treatment. But this exercise helped us in streamlining a lot of the things when we have to take the next patient. And we would have treated this patient on this linear accelerator, which is the state of the art as of now. And let me call Dr. Saini for the.
Good afternoon. I will discuss about the brachytherapy in benign diseases. A rationale for the brachytherapy in benign diseases. Actually, the patient with the benign diseases are having the younger age at the diagnosis, and definitely they will have a long-term survival. So when we decide to give the radiation, first think about the radiation effect. It may include the radiation-induced cancer, so these are very low. So therefore, the radiation therapy technique must be very conformal. Naturally, the brachytherapy, by the virtue of the inverse square law, dose follow, the most conformal radiation therapy technique. Hence, whenever possible, brachytherapy should be preferred in order to have a minimal dose to the surrounding organs and to give the optimal desired dose to the target area. Brachytherapy have an advantage nowadays due to the high dose HDR technique, that it has a short treatment time, and there is a vast radiobiological experience of the clinicians for this technique. And it also avoid the overburden on EBRT machines. Brachytherapy in benign diseases are delivered by the surface mold or plaque brachytherapy, intracavitary or intraluminal brachytherapy, or nowadays it is getting popularity, interstitial brachytherapy, due to the advancement in the imaging. A few of the clinical indications of the brachytherapy are the hypertrophic scar, keloid, and few of the other benign diseases where the medical treatment failed. Age-related macular degeneration, pterygium, ocular vascular malformation, coronary artery restenosis, and peripheral vascular restenosis. Now come to the keloid. Keloid is an excessive tissue proliferation after the injury from the surgery, heat or chemical burn, or sometime inflammation like acne. The keloid have propensity to regrow even after the surgery. So after the surgical treatment, radiation therapy in the form of 20 to 30 gray is given usually within 24 to 48 hours of the keloid excision. Usually it is given after the excision, but sometime if it is not feasible after the surgery, then it can be given earlier. And the brachytherapy is optimal technique for the keloid treatment and always should be preferred wherever it is feasible. Both the mold and interstitial brachytherapy are used, and it has shown to be effective in almost 100% of the cases where it is used appropriately. This is a diagram that is showing the brachytherapy applicator, the sutural line after the surgical excision. This is a case of post-burn keloid that was treated with the brachytherapy applicator, interstitial applicator, and a single applicator was inserted. These are the few of diagram where the brachytherapy beautifully control the disease. In the first case, there is a keloid of ear after the ear piercing. That patient was treated without the surgery, and there is excellent outcome with the brachytherapy. In the second case, there is a keloid on the chest wall. It was also treated by the interstitial brachytherapy. There is no dearth of the knowledge or the experience regarding the use of brachytherapy in keloid, and it has shown that it is well tolerated and had no significant side effect except the erythema for few days and sometime hypopigmentation only. And now the role of the interstitial brachytherapy in the form of high dose rate brachytherapy, the volumetric approach is in the vogue. Wherever the brachytherapy is used, usually 4 to 6 gray in a 3 to 5 fraction is used at the 5 mm distance from the source, and the doses are around 20 to 30 gray, and the local control approaches around 100%. Now, something about the intravascular brachytherapy. It is used for the management of the drug-eluting coronary stent restenosis and peripheral vascular disease where restenosis develop. Prescribed dose is around 15 to 20 gray is at 2 mm from the source, the intracoronary disease, and 2 mm beyond the lumen radius in peripheral arteries. The treated volume in the intracoronary disease is around 2 centimeter, but in the peripheral vascular disease, it may be up to 5 centimeter. Usually, beta emitting sources are preferred over the gamma sources due to the higher dose rate and more localized dose distribution. Most commonly, strontium or yttrium 90 is used for the interstitial intravascular brachytherapy, but tungsten, vanadium, and phosphorus are equivalent for this purpose. But some centers also use iridium and iodine. This cartoon shows how this intravascular brachytherapy work. When stenosis developed, angioplasty takes care the lumen, but due to the neointimal hyperplasia, it again develops. And with the help of the brachytherapy, the chances of restenosis reduced up to the 50%. These trial mentioning that around the chances of the restenosis after the brachytherapy reduces from 20 to 25% to 10 to 12%. And the few of the ocular indications are neovascular age-related macular degeneration, where around 20 to 25 gray of brachytherapy doses are given. Retinal capillary hemangioma, vasoproliferative retinal tumor, choroidal hemangioma, where 25 to 50 grays are given by the plaque brachytherapy. And in case of the pterygium, where 3 to 6 gray in 10 fractions, 1 per week is given. Usually, iodine 125, strontium 90, or palladium 103 radioisotope are used. This is a novel type of strontium 90 applicator that is placed into the position followed by a pars plana vitrectomy. This strontium 90 source is applied to the lesion, and the dose follow-up is around 10% for each 0.1 mm. So the normal tissues are spared and only lesion is treated. So there are less chances of the toxicity. This applicator. The plaque brachytherapy, these plaques are from 10 mm radius to around 22 mm radius. The effect of the plaque therapy can be seen in this diagram in the right side, case of choroidal hemangioma, where we can see that This is retinal detachment interiorly, and B scan. Here we can see the collection and retinal detachment, and here is a hemangioma. After the brachytherapy, this detachment resolved, and the hemangioma size is also reduced. Now I invite Dr. Anil for the audit of the radiotherapy.
Thank you, sir. So I'll be trying to, so there's less time, so I'll try to skip my slides. So, I'll be presenting audit of radiotherapy in benign diseases. So it is taken place in Department of Radiation Oncology from the period of 2005 to 2020. So we have not taken diseases such as pituitary adenoma, meningiomas, craniopharyngiomas, which has very established role of radiotherapy. So the total patient registered in RT department in this time period was 24,904, and in this we have treated almost 15,000 of patients with radiotherapy, and among this total number of patients treated for benign diseases was very less. It is 130, almost less than 1% of the total patient treated. So coming to the patient and disease characteristics, so age range was 6 to 66 years with median age of 40 years. More than 2/3 were males. As if we see the year-wise distribution, from the period of 2005 to 2018, we had less than 10 patients, but in 2019 and 20 we had more patients. In 2020, we can see that 10 patients were of COVID pneumonia patients, which were treated under trial. So coming to disease categories, so maximum patients were of hyperproliferative disorders, and the second were degenerative, inflammatory, functional, and as well as infections. So this is the disease profile which we have treated from 2005 to 2020. So maximum patient we have treated is myositis ossificans, and followed by juvenile lisangiofibroma. We've also treated glomus jugular keloid cases. Also we have treated 4 cases of AV malformation, Graves ophthalmopathy, and hemangiomas. We have also treated 2 cases of uterine fibroid, which were medically inoperable, and patient had a lot of bleeding. So as discussed, COVID patients, angiokeratoma, Bowman's disease, systemic sclerosis, even fibrous dysplasia, Langerhans cell histiocytosis, Karen acanthoma, Castleman disease, even amyloidosis, as Madam has discussed, Isis-Bilby case also. So, so what was the indication for delivering radiotherapy? So, as we know, it is the last resort. So, the most common indication was inoperability, as we have seen in juvenile laser angiofibromas. The second most common was prophylactic RT, as we do in the keloid cases and myositis ossificans. Then recurrence or refractory cases, as in the neomycetoma case, post of RT such as PVNS and COVID cases. So what is the dose range we have treated? In hyperproliferative, we have given the intermediate doses of 20 to 45 gray. Degenerative, we have given from 7 gray 1 fraction to 50.4 gray. Inflammatory, we have given very low dose to intermediate doses of 25 gray. And the functional, we have given in the range of 50 to 60 gray. Acute infection, we have given very low dose of 0.7 gray. So overall, dose range varied from 0.5 to 60 gray in 1 to 30 sections. So coming to the treatment response, so treatment response was 60%, with no response of 5%, and 35% lost to follow-up. So the major question comes is, what is the meaning of response in this? So the response can vary, and in case-to-case basis, response may have a different meaning. So I'll be trying to discuss 2 cases where the response has the different meaning. So first case is refractory eumycetoma of foot. The patient was 41-year male, diagnosed as eumycetoma 9 years back, with 4 lines of antifungal therapy with 2 times surgical debridement. Still, there was multiple recurrences, and patient was unable to stand even with support. So the indication for RT was, only option left was amputation. So we were called to salvage the situation. So here you can see that there is tumification, there is a sinuses, and there is cannulation discharges. And you can see that the calcaneal bone is invaded by the tumification. So we took the challenge of delivering the radiotherapy. So in the planning CT was taken in the treatment position. The wax bolus was applied to cover skin area also. So bilateral beams were applied over this area. Here you can see this is the tumification part, and we have also covered skin. We delivered 17.5 Gray in 5 fraction in 5 days by 2 lateral beam. So this was the situation before RT, and this is the situation after 2 years of RT. So here you can see there is resolution of tumification, resolution of granulation and sinuses. So patient is able to work, and we were able to salvage the situation, and so we were successful in our target. So next patient is PVNS, a 66-year female with slow growing swelling over the dorsolateral surface of the left index finger for 1 year. It was associated with pain and restricted movements. Patient underwent wide local excision, and histopathology showed PVNS with unknown margin status. So pigmented villonodular synovitis are very notorious for local recurrences up to the range of 25 to 45%. Radiotherapy can control and bring down the local recurrence to 4%. So patient had high risk of recurrence as the margin status was unknown, and patient probably had neurovascular bundle involvement as suggested by association of pain. So we planned for surface mold brachytherapy, and the affected index finger, a cast was made, and wax bolus was covered, and we placed five catheters equidistantly of around 1.5 centimeter, as you can see in this, and we loaded only 4 catheters. Here you can see the dose distribution. So we gave 30 Gray 10 fraction in 2 weeks by surface mold brachytherapy. In 3 weeks, there was increase in inflammation, pain, and restriction of movement. By 8 weeks, there was desquamation, and by 12 weeks, patient started healing. And here you can see after 2 years, there was complete recovery, and patient had a complete patient had no local recurrence. So in this, response is absence of any local recurrence. Now I invite Dr. Dean Sharma sir for concluding remarks.
Before I wind up, I just want to address one important concern. It is very genuine concern that whenever we deliver radiation for a benign cause, there is always a probability of the risk of developing the cancer. But that risk must be weighed against the condition which we are treating. Anytime the morbidity of the disease must be maybe much more devastating than the risk of the radiation-induced cancer. And in COVID-19 trial, when we were delivering the radiation, there was also a concern. We took the help of our physicist, Dr. Subramani, assistant professor, and he developed a model by which we could calculate the risk of radiation, risk of the secondary cancers. It was found that it was less than 1%. During the initial part of the COVID, when there was a lot of fear, the less than 1% radiation-induced cancer was quite minimal and quite minuscule. So that's why we could go ahead with the trial. So when we think of the radiation-induced cancer, there are certain factors are to be kept in mind. First is that we all carry a certain amount of risk of developing the cancer. Even if you don't have get the radiation in our lifetime, we have that risk of developing the cancer due to various other factors. That must be kept in mind. And then the risk which we are estimating with the dose of radiation is dependent on many factors. One is the dose of radiation. The less the dose, the lesser the risk. And nowadays, with the modern radiation, the dose to the normal tissue is quite minimal. Therefore, the risk is further minimized. The organ which is being irritated as an accidental organ due to the while treating the benign conditions, and there are certain organs which are not at very high risk, and but there are certain organs which are at risk. For example, thyroid in children, when we give even a minimal radiation, at the risk of developing thyroid cancer. So that depends which organ is in the vicinity of that treatment. Then volume of tissue irradiated. The larger the volume, larger the risk, and therefore smaller the volume, smaller the risk of radiation-induced cancer. And therefore, we always try to curtail the dose to the adjoining tissues so that the risk is minimized. Age at the exposure. If children are more prone for developing secondary cancer simply because they live for a longer time, and at the same time, the elderly patients like 70 years, they don't have that high risk. And there is a definite lag period after the exposure. If we give a radiation today, patients are not going to develop the secondary cancers tomorrow or day after tomorrow. usually there's a lag period of about 10 years and sometimes even 20 years also. So if you deliver radiation to a 60-year-old male or female, he or she will develop the radiation-induced cancer after like at the age of 80 years, which might be acceptable, which might not be concerned. Therefore, the risk of radiation cancer is overemphasized and overprojected, which must be kept in mind. And I think so that risk is against a condition is not very high. Just to summarize, the different effects of radiation are used to exploit the treatment of benign conditions. There is wide range of benign diseases which are treated by radiation treatment, as we have seen in the different talks. It should be used as a last resort and not as a first option for the treatment. And when we decide to treat any benign condition by radiation, then we must choose the most conformal technique of the radiation treatment. And usually low doses are required, but if you see the median dose of radiation required for benign is usually about 20 gray, and the risk of radiation carcinoma is very trivial and very minimal. It should not be a deterrent for treating the benign condition with the radiation. Thank you very much. And before we take the question answers, we request Dr. Nitish Naik. He's here. He's Professor of Cardiology, and we are doing a trial. We are planning to do a trial. He and Dr. Narang. So, just comment that. Do you see a future of the SBRT for the ventricular tachycardias? Please, you can come here.
I agree with you that radiotherapy is coming as a new emerging technology for the treatment of serious ventricular arrhythmias. And these arrhythmias are often very life-threatening. Although we have called them benign, for us they are very malignant because these, I think so, they are sometimes quite untreatable. They are unreachable, and the existing therapies may not be able to, address them well. So I do feel that this is something that is quite promising, and this is something that would be interesting to see how this develops. Because when it comes to the cost factor, like Harish pointed out, there is something that may be in benefit of the patient, especially when it comes to government hospitals. But overall, yes, this is something that needs to be proven. There'll be a lot of ifs and buts before the benefit is realized. But from whatever existing data is available, there seems to be a lot of promise in this. And I hope at least we can take off this trial quite soon.
Thank you, Dr. Naik. We look forward to doing this trial. It's being considered by the ethics committee. So once we are through that, I think we'll be able to produce some data, and maybe we can benefit these patients who have no option, no practical options. Any questions or comments? No comments? That means you understood everything or nothing? I think we are in time, but it's in time. Okay, then. Thank you very much. Thank you.